Good morning. Today we are going to have a very interesting session. The interesting session is because of various aspects. One, it is a very important life-saving situation in dermatology. In fact, one of the emergencies in dermatology is adverse drug reaction, that too severe adverse drug reaction. It could be very trivial or it can be life-threatening also. Second one is social implication. Social implication means that you are amongst an anxious, a group of anxious people who are questioning you or who is inquiring you about the patient. And you are in a stressful situation of how to manage the situation, and you may be facing with a lot of problems. And during the treatment, you are confronting a number of challenges like the infection, the electrolyte balance, the water electrolyte balance, the hydration, the nutrition, and a number of factors. Moreover, once the patient is coming out of the drug reaction, severe adverse reaction, the psychological aspect of this disease is something which something which many of the dermatologists forget about that. So we have to support that psychological aspect. And mainly post-adverse drug reaction syndromes, I should say, it is a post-adverse drug reaction syndromes. That is quite is ignored. And we have to look into the various post-adverse drug reaction problems. So we are going to have a plethora of problems, and we have to understand the drug reaction properly. And starting from simple urticaria to Steven Johnson or toxic epidermal necrolysis, there is a wide range of cutaneous adverse drug reaction. And we are fortunate to have a very good speaker, that is Dr. Abhay Martin. And I'm sure that Dr. Abhay Martin is very well known among you. However, I will just introduce him for the sake of introduction. Dr. Abhay Martin is the head of the Department of Dermatology in Baby Memorial Hospital, Kozhikode. And he has authored a very important textbook, or rather he has edited a very important textbook on adverse drug reaction. So if you haven't come across this, kindly get one copy and keep it with you. And it has a very, treasure of knowledge about adverse drug reaction. And moreover, Abhay is a very good orator, and he had so many interests in dermatology. And if you have any doubt about adverse drug reaction, you may contact him, and he is very willing to help you. So, over to you, Abhay.
Thank you very much, sir. Thanks for that introduction, and thanks for a very succinct approach to cutaneous adverse drug reactions. As you rightly mentioned, I think cutaneous adverse drug reactions, especially the severe cutaneous adverse drug reactions, would bring into focus our expertise in internal medicine. Because as a dermatologic physician, I think we need to have a sound knowledge of internal medicine. It also brings into the fore how you manage challenges on a day-to-day basis, how you assess an individual for the severity of the reaction, and you take risks on the way, whether it be the treatment risks, whether it be the communication risks, or it could be hand-holding which might be required at the as the disease progresses. So all in all, from the time the patient is wheeled into your outpatient or the emergency, until the patient exits out, as well as he follows up, there can be anywhere from lack of trust. It starts as lack of trust with the previous doctor or with you yourself, and it can progress on to gaining trust, and patient will be extremely happy if you have given them a good output. Every postgraduate should be trained in management of adverse drug reactions, and they should know how to recognize, how to identify the complications, as well as they should know the art of liaison with other specialties, because I'll be showing you a few slides where we actually liaison with so many other specialties. So without much ado, I'll just share my presentation. Is my presentation visible, Naveen and sir?
Yes, doctor, visible.
So I have a fondness for this very elderly, statesmanly dermatologist, whom the older generation would know very well, Walter Brown Shelley. He put a very apt statement which is relevant in cutaneous adverse drug reactions. A history is never complete until you have the diagnosis and the patient has the cure. So rightly said, with many diseases, and more so with adverse drug reactions. I'll give you an anecdote of what happened several years ago, way back in 2013. It's the story of this couple, and this gentleman is Dr. Kunal Saha. He and his wife, Dr. Anuradha Saha, came down from the US. He is an HIV researcher, and he came down from the US for a holiday to Kolkata. And she developed, unfortunately, a fever followed by a severe cutaneous rash all over the body. It was diagnosed by the physicians as a case of vasculitis and treated with very high dose of steroids, dipomedrol. And then subsequently, from that hospital, patient deteriorated. A dermatologist was called in very late, and then a diagnosis of TEN was made. And the patient was airlifted, in fact, to a hospital in Mumbai, and she expired there. But the story didn't end there. At that point in time, Kunal Saha took upon himself to have a legal fight with the doctors who had treated. And that fight, which started in 1998, went on till 2013, when he finally was able to get a verdict of 11.1 crores. So this hospital had to pay a record 11.41 crores as compensation to this doctor. So he went through every stage, the state Consumer Redressal Forum, then the National Consumer Redressal Forum. He went through the state High Court, then he went to the Supreme Court. And finally, the Supreme Court gave directives that the doctors had been negligent because they had given high dose steroids. Now, that was when our IADBL president, Dr. Venkatram Mysore, entrusted Dr. Lalit Kumar Gupta sir and a few of us to revise the guidelines, because there was no documentary proof that you can actually use steroids or should we use alternative drugs in a resource poor setting like ours. So we had to go in and find out the backup data for that, and that is how we came up with the guidelines for the management of Stevens-Johnson syndrome and toxic epidermal necrolysis in 2016. And this is, as of now, the latest that we have. We'll be coming up with an update probably in a short while. The groundwork has not started, but we are at it. Now, this term SCAR, or severe cutaneous adverse drug reactions, is a generic term, often used for very severe life-threatening disease of drug-induced etiology more often. It was first used by another great gentleman, Rougeau and Stern. Stern is his colleague in an NEJM article in 1994, and included all drug reactions that are extensive, which have serious systemic involvement and are potentially fatal. Now, this is a review article which actually first used the word severe adverse cutaneous drug reactions. Now, he included a set of diseases which he considered as very severe and potentially fatal. Include Stevens-Johnson, toxic epidermal necrolysis, also called Lyell syndrome, hypersensitivity syndrome, which we now call as Dress syndrome, small vessel vasculitis, serum sickness-like reaction, anticoagulant-induced necrosis, and angioedema. But strangely enough, over a period of time, only these 4 are being considered in SCAR. That is Stevens-Johnson syndrome, AGEP, or acute generalized exanthematous pustulosis, drug reaction with eosinophil and systemic symptoms, and generalized bullous FDE. Some include also urticaria and angioedema, but most of you all know about management of urticaria and angioedema, so I will not be alluding to in that. However, the expanded definition I also feel should include drug-induced vasculitis and erythroderma. Very often these patients have a potential for severe life-threatening conditions. So in our textbook, we have included only 4 of these in the SCAR module, which might see a revision later on. But most review articles will look at only 4 of these presentations. Now, there are certain prerequisites to understanding SCAR reactions. First, you should understand the concept of acute skin failure, which needs to be understood based on the loss of normal physiological functions in the human body. I would ask you all to go through an article by Dr. Arun Inamdar sir, who has written a wonderful review article on acute skin failure. And we should know that the rash can actually help in identify the diagnosis. We can identify an EM versus an SJS or a TN. Sometimes we can differentiate between a generalized bullous FDE versus a toxic epidermal necrolysis based on the type of rash that we get. Having said that, there can also be overlap of clinical features where you might be finding it difficult to identify whether it is an SJS or is it a dress or is a viral exanthem. And certain drugs or groups of drugs are known risk factors for SCAR reactions. And certain comorbidities actually predispose individuals to SCAR reactions. Like, for example, a diabetic who has an altered metabolism and altered immune response, a renal patient who has an altered excretion, a connective tissue disease who has an altered immunological function, malignancy also, HIV patients also. So these are all comorbidities which you should always ask for in the history when you are actually dealing with the SCAR reaction. And there's also a potential for systemic involvement in sepsis in these patients. So every day there should be a watch out for early signs and symptoms. So you should know what an ARDS is or an adult respiratory distress syndrome is. You should know how to recognize an erythema, electrolyte imbalance. You should be able to identify sepsis. You should be able to identify whether the patient is going in for failure, cardiac failure, renal failure, hepatic failure. All these medicine knowledge is essential when you are dealing with severe cutaneous adverse drug reactions. And increasingly, we are identifying that it's not the drug alone. There is a role for genetics as well as viral infections, and that is an evolving area of research now. And we have to, as I mentioned, we have to engage multiple disciplines: the dermatologist, the allergologist, immunologist, clinical pharmacist, burns, surgery, ICU care, ophthalmology, gynecology, and more importantly, the psychiatrist also, because they go through a very traumatic experience during this care. So how do you evaluate a patient who is a suspected SCAR patient? So my stepwise clinical diagnosis, suppose a patient comes to me like this. He might come to me from the outpatient, from the emergency or a ward or a consultation call. So there's a patient with a fever and a rash. Patient has a mucosal eruption, may or may not. Patient may be having a comorbidity, which should be inquired. Systems may be involved. There'll be history of drug intake. And a dermatology opinion is sought saying that these are the features and please give your opinion. So I'll give you the example. A 25-year-old lady, a fever of 2 days duration, myalgia, fatigue, sore throat, conjunctival congestion. She reported to the GP in the periphery. She was prescribed amoxicillin with clavulanic acid with a cough syrup and a mefenamic acid. 2 days later, she reported to the dermatologist with maculopapular rash, minimal itching with a cephalocaudal progression. And she claims that it is drug induced. She's angry with the general practitioner and she has approached you in a hospital or in a clinic saying that this is what has been done by the previous doctor because of which this is. So you're sitting in judgment as to how to tackle this particular individual. So you have to look at whether it is going to progress, whether it is a viral exanthem, whether it is a drug related, whether the drug had a role or the virus plus the drug and the immune system of the individual. All of these you will have to manage at this point in time. So you have to arrive at a diagnosis. So first analyze the fever, the sore throat and the malaise. Ask for the history, the duration, the type of fever, whether the rash occurred after the fever. Usually in drug or viral, it will occur after the fever. Or if it was a fever after the rash, which may occur in an inflammatory condition. First the rash arises, then the patient becomes a lot more febrile. Even in connective tissue disease, it can happen. So Analyze the sore throat in detail. Does the patient have a dysphagia? Does the patient have an odynophagia or a painful difficulty in swallowing? Is there drooling of saliva, which is a very subtle marker that the patient is not able to swallow? Is there involvement of the accompanying lip, the buccal mucosa, tongue, pharynx, and esophagus? Does the patient complain of burning, or is it itching in the mouth, or is it a pain, or is it a itchy throat sensation only? So a mild itchy throat sensation could well be a small viral infection would come and go. You would not be starting a steroid or a immunosuppressive in such patients. So it's necessary that you actually ask the history properly and also examine the throat very well. When it comes to the drug intake, when was the drug taken, or when was it prescribed? How long was it taken for? What is the latency between the drug intake and the rash? Was there any previous history of allergies? Was it inadvertently? This patient already had a penicillin allergy, or a patient had a mefenamic acid allergy, and she was prescribed it again without the knowledge of the general practitioner. So was there a history of reactions in the past? And if so, the person has to describe what happened. And even the rash has to be evaluated very carefully. What's the type of rash that you're encountering? Is it a macular or a papular, a maculopapular or exanthematous rash, which might give a suggestion whether it is a EM or an SJS or a dress. If it's an urticarial, it can have EM can sometimes present with urticaria-like presentation along with a maculopapular-like rash. Is it vesicular or bullous? Then you might be dealing actually with a bullous fixed drug eruption, or even EM, even SJS, and even TN can present sometimes with vesicular or bullous lesion. So again, you narrow it down once you start getting vesicular. Even spongiotic reactions, severe edema can actually produce mild vesicles and bullae which easily erode off. So there one might even consider the possibility of a immunobullous disorder. So there again, there are confounding factors. If the patient is coming with a pustular eruption, so you might consider that it could be a AGEP, or it could be a pustular psoriasis. Or if the patient is presenting with a purpuric rash, so are you dealing with a vasculitis, or are you dealing with an EM, SJS-TEN, or a Dress syndrome? If you are lucky to get target lesions, either typical or atypical target lesions, that also will give you an idea that you are probably dealing with an erythema multiforme. So likewise, you also should look at the type of progression. A cephalocaudal distribution, like occurs characteristically in Dress syndrome, where the patient develops a facial edema and then the rash slowly progresses downwards, and there is gross cutaneous edema and tenderness and vesicle formation occasionally. So, and the rash progresses in such a manner. So that may be an evidence that possibly the patient is dealing with a Dress syndrome. Or an extremities to trunk, like predominantly drugs, EM would present on the extremities. That may be a clue with palms and soles involvement. So you examine which are the areas which are involved. And then you go in for the regional distribution. Whether it is only trunk, then you think in terms of TN or an SJS, predominantly trunk, some amount of extremity involvement. Flexural, then you will start thinking in terms of a generalized exanthematous pustulosis. Relation to the fever, as I mentioned. Facial puffiness goes in favor of dress more often. Not that it is absolute, but it goes more often. Cutaneous edema and tenderness, again, more often. Lymph node enlargement. Then you have to think whether the patient had an acute presentation of lymph node enlargement, think of a viral etiology. So you should always, when you finish the examination of the face and the neck, always make it a point to go and examine the cervical lymph nodes to identify if they were pre-existing or if they are tender, if there is difficulty in swallowing along with this. So that may be a pointer to suggest that there is a viral infection overlap. Likewise with the mucosa, in the eyes, ask for all these symptoms: redness, pain, photophobia, discharge occurring, blurred vision, dry eyes, eyelash issues, or the patient, you should also do a corneal assessment. Never forget to run a torch and see if the patient has actually photophobia or a corneal involvement. Also examine the sclera and the conjunctiva. These are accessible to you. From there on, behind the cornea, the lens and all and the retina are accessible only to the ophthalmologist. So, but your preliminary examination should have, when you do a head-to-toe examination, also make it a point to do a mucosal examination. Because now, Stevens-Johnson syndrome with severe ocular complication, this is the new entity, SJS-TEN SOC, is a distinct entity identified lately. Likewise, oral mucosa, ask for redness, burning, odynophagia, focal lesions only involving the lip and the buccal mucosa, or is it diffuse? Is it hemorrhagic, which goes again in favor of a EM-SJS-TEN spectrum. Never miss looking at other mucosae. Once the oral mucosa is done, very often you miss asking or looking at the genitalia because you are squeezy or squeamish about examining the patient. The patient may not allow you to. So get the patient into confidence, examine the genitalia completely, and also examine the anal mucosa, ask for the nasal mucosa involvement. So if you do it step by step, you will not miss it. So make it a point to examine these mucosa, and never forget to examine the palms and soles. And you might get clues very quickly for an EMSJS or even a hand-foot-mouth disease when it is a severe vesicular eruption. And now that you have done that, go in for systemic involvement identification. Ask for history. If the patient is coming to you with delirium, restlessness, or drowsiness or irritability, it is straightforward. There is some amount of CNS involvement, which may be related to the Scar reaction, or it could be related to an electrolyte imbalance, or it could be a viral encephalitis. We do not know. But whatever it is, you have documented that, you've identified that. Patient may be emotionally labile because the patient may be having a low sodium or a hypoglycemia, or a patient maybe have a hyperglycemia, which may be causing a drowsiness in the background of a diabetes. Patient may be angry and depressed at different times in time because patient has so much of pain. Insomnia may be present because the patient has been given a medication or has not slept for so long, or the presentation may be in the form of seizures. All of these suggest that there's a CNS involvement. CVS, always look for tachycardia and bradycardia. It can be an early recognition of sepsis. Hypertension also. Hypotension especially is more important because sepsis can be identified very fast. Arrhythmias, keep a hand on the wrist and identify whether there is a rhythm disturbance, pulse. So that actually is not only hand holding, but also in the process, you're actually identifying if the patient is having a rhythm disturbance or a cardiac involvement. Respiratory, look for dyspnea, hypopnea, shallow breathing, put a stent if necessary, and see crackles and rhonchi because the patient may already have been having a pneumonia. Like for example, during SARS-CoV, we used to have patients who presented with Stevens-Johnson syndrome and even generalized Bullous FDE who actually had very bad crackles. So we never know what we are dealing with. And in such instances, when they have upper respiratory, always make it a point to wear a mask yourself. Your protection is as important. GIT, gastritis, esophagitis, enteritis, diarrhea, all are important because you're giving drugs orally at many a time. And these need to be looked at. Abdominal distension, ascites, tenderness. These may be instances where the systemic involvement or a hepatitis may be there, or a patient may be having a very bad peritonitis. So if the patient is coming late, so this examination should never be missed. That's why I say, as a dermatologist also, you should never forget the basics of your internal medicine, which you studied in MBBS. Sepsis, there are features which will give you features of sepsis. Is a patient is having fever, patient is having tachycardia, bradycardia, arrhythmia, altered sensorium, or patient is in hypotension. Think of a very quick SOFA, this is called. It's an assessment for sepsis. So increased breathing rate, altered mental status, and low blood pressure are very key signs to suggest the patient is in sepsis. Now also analyze the comorbidities. So because each of these instances can actually increase the risk of scar, the disease progression can be very erratic and very severe and unpredictable in these set of patients. And these multiple factors, including the way they metabolize the drugs, the amount of glycemic control that you're having in a patient with diabetes. Patient is already hypoalbuminemic, which means patient is having an acute skin failure with hypoalbuminemia. The patient is going to have a lowered immunity. The repair mechanisms will be poor because protein synthesis is very poor. It can also occur that these patients will have ascites with some amount of pleural effusion. These patients may be having a difficulty in third space accumulation will occur dramatically. So these patients require analysis very, very critically and very carefully. The time spent in analyzing these patients is well worth it because at the end, the outcome is much better. You have recognized it early as the patient and the bystanders get a confidence that you are actually handling the patient in its entirety. And you should be the pivot around which all the other specialties will be able to work upon. Not necessarily that you should admit under you. If you have the confidence to admit under you, go ahead. But otherwise, if you're in an ICU also, but you should be the pivot and they should be able to work around you, and for which you should have a working knowledge of internal medicine. Electrolyte imbalances should also be recognized very carefully, especially hypokalemias. They lead on to arrhythmias and use the patient very frequently. So make it a point to send electrolytes quite frequently during a week. If you have any suspicion of dehydration or a patient is having slurring of speech, which suggests the patient is having fatigue, it could be a hypokalemia. Check glucose sugars every day, and likewise also keep a tab on the pulse rate as well as the albumin levels. So polypharmacy is very common in these patients, and therefore you should know whether you are having drug-drug interactions. Or even as simple as somebody who has been given a gliptin may be having hypoglycemia because the patient is on a hypoglycemic drug, and you're also giving something else additionally which another doctor prescribes. So 2 different antibiotics may be prescribed, or a physician may prescribe for a gram-negative coverage, but your organisms may be staph, so gram-positive may not have been covered. High-end antibiotics, necessity is there or not, you can actually judge. So unless you know what you are doing, it will be very difficult for you to diagnose these patients. And all these patients have altered pharmacokinetics. So their excretion, their distribution, everything is improper. The commonest scenario which we encounter is it a drug rash or a viral rash? So if it is a drug rash, the most common drug rashes which we encounter, at least I encounter in clinical practice, is analgesics, antibiotics, and anticonvulsants. And the common viral infections which we encounter here are Epstein-Barr virus, CMV virus, HHV6 we don't usually test for, and of course measles and rubella may also be mimics. So I'll give you a small algorithmic approach or a tabular approach which will actually help you to differentiate. Both have prodromal symptoms, so it's very difficult to do based on that. Both have pruritus, but pruritus is more likely to be in a drug reaction. Look at the mucosa. You will find certain classical mucosal rashes like Koplik spots in measles, Forstheimer spots in rubella, or a hand, foot, mouth disease will have these lesions in the oral cavity where small vesicles, intact vesicles may be seen, especially in children. Hemorrhagic or crusted lesions actually gives you more idea that it is probably a drug. But I'll also come to a confounder here. There's something else called Rime or mycoplasma induced or such other viral infections where they can also be hemorrhagic crust. I'll come to that later. But at least you've narrowed it down to 2. Either it should be a Rime or it should be a Steven Johnson or a TA. Palms and soles. As I mentioned, HSV associated erythema multiforme. Is it a viral associated or it's a drug induced? So based on the history, you will be able to. Pain will be more prominent in these patients who have drug induced, right? Along with that, it's a more severe form of erythema multiforme that you see in those with their drug induced. Systemic symptoms, both can present with systemic symptoms, depends on when the patient comes to you. Lab parameters, if you are lucky, eosinophilia is a useful marker. But the fact that you didn't get eosinophilia does not mean that it was not a drug reaction. Even then, neutrophilia can be a response, or you can sometimes even get monocytosis. So as I usually send a peripheral smear, so to identify if there is any atypical lymphocytes, which might suggest and go more in favor of a viral rash. Or even I might pick up a malignancy with a peripheral smear. So I never miss the opportunity to send a peripheral smear as a differentiating point in such cases, right? And treatment-wise, one does not need steroids, the other needs steroids. So it is essential that you go through this checklist so that you know whether it is a viral or a drug-induced. So this is the presentation of a lady who actually presented with a viral erythema multiforme, initially prodromal symptoms, and she got better because we identified the drug. If you are lucky to get these targetoid, atypical targetoid or typical target lesions, then you are again justified that it should be either herpes associated or it should be a drug induced. At least you've narrowed it down to those. Bullous lesions can occur on the palms and soles when there is severe inflammation. So as I was mentioning, this gentleman had painful blisters, and he also had rashes on the extremities predominantly. So we knew that was a case of EM. He also had mucosal lesions. So it was a EM major, and he had been on penicillin group of drugs. So we were able to give treatment with steroids. So we knew that was not a viral EM. So this is what I was mentioning too. Now we have this particular entity called reactive infectious mucocutaneous eruption or Rime. It's also known by other terminologies as mycoplasma infectious reactive exanthem or MIR. So all of these are synonyms that are used because earlier only mycoplasma was found to be associated. Now we know that more than one drugs can act, more than one viruses can cause this presentation, which includes HSV1 and 2, Mycoplasma pneumonia, HIV, and SARS COVID-19. We had quite a number of patients during COVID who presented with this sort of a presentation, almost like SJS-TN, with no drug being taken, no drug history associated. So here is a mimic of a Stevens-Johnson TN syndrome. So this was actually initially described in 2015, but later on numerous other pathogens were also identified and added to the list. So now that is why the new terminology is reactive infectious mucocutaneous eruption, no longer called mycoplasma induced. So this is a textbook picture of a mycoplasma induced. It's EM lesions, but you will see a few hemorrhagic lesions. But this is in COVID, and this is a personal case of mine who actually presented with, and we were able to prove that it was actually mycoplasma. And this patient looks almost like Stevens-Johnson, EM major or Stevens-Johnson, and that we were able to pick up only because we did a mycoplasma. But there was no drug history at all in this gentleman. So here is a mimic of Stevens-Johnson and erythema. So how do you differentiate between Rime and EM? So most often viral etiology here, it can be drug, viral, systemic illness, or malignancy in EM. Mucosa, prominent mucositis in Rime. If you are lucky to get a targetoid rash, think in favor of an EM. A viral PCR will help. If you have some facilities for those, you can do a viral PCR, or you can do at least an IgM or IgG for EBV or for HSV, which are easily accessible. But the other ones, like for example, being in a corporate hospital, it's easy for me to send such. It will not always be possible in resource poor settings. I send sometimes an ACE, which stands for adenovirus, cytomegalovirus, and an EBV virus. So we get PCR positivity, and from there we take a lead. So viral markers are being done increasingly now. We have COVID tests being done for antigen positivity. So likewise, if you have the access, please go ahead and do that if cost is not a factor. But strangely enough, here is one condition, though it is a viral infection, we are still giving steroids as treatment. So either way, the treatment being steroid, but you have identified an etiology to that, because EM, if it is drug, you have to issue a drug allergy card. Whereas if it is a Rime, you know that these patients are going to have a 1 or 2 times. Very rarely relapses occur. Now, having said that, these 4 different presentations, one side you have Stevens-Johnson, on the other you have TN, which is recognized by peeling of skin in sheets. You have generalized pustular eruptions, which is a characteristic of AGEP, and you have diffuse erythematous rash involving most parts of the body with edema. Though these look as very distinct entities, there can be a lot of overlap, because this is Dress syndrome, but you can still get a purpuric rash in Dress syndrome. This is TN, you can get a Bullous FDE, generalized Bullous FDE presenting almost like a TN. You can get a EM or a TN-like presentation in Dress. That is one of the manifestations. You can get a pustular eruption in Dress. So there is still an overlap which can occur. So this is something which has to be kept in the back of the mind. Recently also, we had a colleague of ours, a doctor who actually was prescribed ATT, anti-tuberculous therapy, and he presented with very classical SJS-like eruption. He had mucositis, he had a generalized purpuric rash, he had a maculopapular rash also, he had urticarial rash. So we were confused whether we are dealing actually with a Stevens-Johnson. He came and told us, I have Stevens-Johnson, to probably anti-tubercular therapy. So while we did the workup, we realized that he had a EM SJS-like Dress syndrome, because his eosinophils were really high. He had hepatitis, and he also responded beautifully to corticosteroids. And we were also able to identify reactivation of a virus. He was CMV positive, which he didn't know. So there are instances where this acts as a lead point for you to identify reactivation of viruses. And diseases don't read textbooks. Medicine is not always accurate. These are pointers to suggest that these are the entities. But there may be pointers, overlapping features, that you should capture them and document them in your case sheet. Documentation is very important with medico-legal issues arising more and more. So coming to SJS and TN, I'll just go a little bit more in depth about SJS and TN, because a lot of medico-legal issues are involved in this. You all need to know tomorrow when you encounter SJS-TN entirely about this particular entity. So you know the classical presentation, presenting with a fever, prodrome, followed by dysphagia or dinophagia or hemorrhagic lesions on the mucosa, as well as some amount of ocular involvement can occur, genital involvement can occur, and these patients later on go in for complications. Or you may be presenting with a TEN where the sheets of skin are seen eroded, peeling of skin, sheets of skin, and vesicular, very flaccid vesicular eruptions may be seen. So this was actually first described, in fact, by two American pediatricians, Albert Stevens and Frank Johnson. That is why we have the name Stevens-Johnson syndrome. Way back in 1922, they published in the American Journal of Disease of Children. But no discussion on Stevens-Johnson will be complete because without the mention of this particular gentleman, Jean-Claude Rogeau. He was actually working in University of Paris. The amount of research that he has done on Stevens-Johnson and TEN is enormous. At one point in time in the 1990s, he had the highest impact ratio and he had the highest number of articles in any specialty. He is a pride for dermatology, and he has given us so many guidelines and he's given us so much of research he has done on these very critically ill patients. So we can be proud that we have such a leader amidst our midst. He recently expired in 2021. It was a very sad day, that the day when Dr. Rogeau died. He had done immense amount of work, and he led a lot of postgraduates and teachers into this realm of adverse drug reactions. So we know that it is a delayed type hypersensitivity response, and most of these SJS patients have more than 70% are SJS patients have drug as etiology, and in TN almost all cases are of drug etiology. Very rarely we find viral infections like a mycoplasma. Infections are HHV and HIV are may be seen as causes of SJS and TN, and among the bacteria, mycoplasma is also well known to cause. Pediatric cases, in fact, without drugs, they can get SJS and TN with infections. That is to be noted. So if there is less than 10% body surface area detachment, you call it as SJS. For TN, cases with more than 30% body surface area, and SJS TN overlap for those between 10 to 30% body surface area detachment. Now, this is the Bastugi-Glarin classification. Most of you all would have read during your PG days as you are studying. So this classification into Bullous EM, typical targets, SJS, spots with or without atypical targets, then overlap, where SJS and TN will overlap. Then you have TN with spots and TN without spots. So this is the classification which is used in a day-to-day practice also. Which are the most common drugs which we should suspect? So when you have a patient with a polypharmacy, there are certain drugs we will actually put our focus on. So these are the drugs which you should think when you are actually encountering a patient with TN. Is a patient on a sulfonamide? Is a patient on an anticonvulsant, on an antiviral like a nevirapine or abacavir in HIV patients? Is a patient on an antibiotic? So of the antibiotics, most commonly, at least in my clinical practice, I encounter with fluoroquinolones and also with sometimes with penicillins. Very rare that the other antibiotics are encountered, but that may be a subjective matter. Each individual encounters different, especially even in the northern part of India versus the southern part of India, there is a difference, I'm told. So uric acid lowering agent like allopurinol, notorious, very often missed. If you do not look at the drug chart for a drug like allopurinol, you will miss it. And it is well known to cause severe Stevens-Johnson syndrome and TEN. NSAIDs, of course, it's the villain of the piece in most drug reactions. The mortality is quite high. It's almost 22% with TN. 30% with TN, and around SJS TN it has 22%. That is the Europe data, whereas the US data says mortality even there is around 5.4 to 15.3%. We don't, unfortunately, have incidence data and morbidity data in India because there's no formal mechanism by which we try to report it. So all that we know is from certain reports which have been reviewed in journals, and that is what I have taken up here. The annual incidence is not known. Mortality is around 12.94 overall mortality. It is all institutional practice, therefore there will be some amount of bias in this. And drug etiology is there in about 97%. And the three main drugs have been, as I mentioned, antibiotics, antiepileptics, NSAIDs. And of the most common drug was carbamazepine and phenytoin as anticonvulsants, and fluoroquinolones, sulfonamides, and paracetamol in that order. Look at this. In South Indian studies, we saw fluoroquinolones more often, whereas in the West Indian and North Indian studies, it was sulfonamides which were more common. So there again, there's a difference. So how you should know how to differentiate SJS versus TN. What are the things that you should do preliminary when the patient comes to the casualty? What's the type of skin care that you should give? What's the type of mucosal care that you should give? Whether the patient should be shifted to the ICU or can you manage in the ward? Do you want an interdisciplinary involvement? What do you monitor and how often do you monitor? And are you going to use steroid or are you going to use other drugs? And what are the medico-legal implications? This much picture you should have in your mind when you handle a patient with a SJS-TN. Recognition is quite easy when it is SJS and TN. Very classical manifestations are there, except differential diagnosis, as I mentioned, was Rime and the viral rash. So these are some pictures. I'm not going too much into details of this because I'm sure almost all of you all would have seen at least one or two cases. For the uninitiated, especially the first year PGs, these are a few photographs. You can also get the same in our textbook. This is a classical presentation of SJS. These are the guidelines which will be available on the. So your initial assessment checklist for SJS-TN in particular. First and foremost, recommend hospitalization. If the patient refuses hospitalization, document that the patient has refused hospitalization on personal grounds. Unless you document that, you're still liable. So this is a very, very important medico-legal aspect which I'm trying to tell you, because unless you document everything every day, tomorrow there can be somebody raising up an issue. I have had a personal experience where an ophthalmologist gave sulfamethoxazole for a suspected toxocara. Patient went back the second week. Patient said, my redness in the eyes has increased. He said it is part of the disease. And then next week he came. Patient came to the physician. Rather, it was a lady. She came to the physician. The physician referred it to us. By the time it was around the third week, and we took over. Luckily, patient did not have any systemic symptoms. At that point in time, made it a point every day to document every step, what all I had done. And as I thought, my junior was asking, why are you writing so much, sir? I said, we never know what is going to happen. Exactly 3 months later, the Assistant Commissioner of Police comes to my chamber and says, we want a statement from you. They have a case against the previous doctor. So this is something which you should always be watchful for. So document. This is extremely essential when you are dealing with severe cutaneous adverse drug reactions. So drug history, I have mentioned, but never forget to take drug history herbal or indigenous or alternative systems of medicine, at least for a period of 2 months prior to the onset of the eruption. And have a temporal correlation chart. You should find time for this temporal correlation. If you have the formal clinical pharmacist with you, go ahead and get a clinical pharmacist help also. Assess the comorbidities. Take a personal family history of drug reactions. And you should do an initial assessment for airway breathing circulation, urinary output, clinical evidence of sepsis, percentage of body surface area involved, and the degree and extent of mucosal involvement. And they should all be documented. Basic lab test, do a hemogram, liver and renal function, electrolytes, sugar, do a blood culture. Never forget to do a blood culture when the patient comes, even before you start the first dose of the antibiotic. Urine routine and microscopy will give you very valuable information of renal involvement. So never forget to do. Even the patient may be having as much as a dehydration, you might find ketone bodies, which tells you that you have to push in a lot more fluids. The patient may be having casts in the urine. Urosepsis may be there. That can be recognized with the pus cells. So likewise, or a proteinuria may be there. The patient never knew that the patient had diabetes with proteinuria. You may be recognizing it for the first time. Or it may be renal damage must have occurred, acute renal failure. So a lot of these evidences, you can pick it up on the urine routine examination. Never forget also to do a skin swab culture and take a chest X-ray, no harm done as a screening if there is a suspicion even of a small amount of lower respiratory tract infection. This is a snapshot from our guideline. What are the supportive measures that you need to do? Because of paucity of time, I'm just showing you all snapshots so that you all can go back to the guideline and read up. Ideally, an environmental temperature of 30 to 32 degrees is necessary to prevent the hypercatabolic state. Monitoring almost every other day, you should monitor for all these things: pulse rate, blood pressure, respiratory rate, temperature, fluid intake and output chart. And serum electrolytes, creatinine, depending upon how the response to the patient is. If necessary, you need to do also a D-dimer assay or a fibrin degradation products if you're suspecting DIC, especially when the patient comes in advanced stage, right? And also ensure that the patient gets barrier nursing and minimum handling. Isolation of the patient is required and minimum handling, and as far as possible, only if it's absolutely necessary, put in catheters. Catheter is an easy way of making the patient forgetting about the patient, because once you insert the catheter, it is an invasive thing and you're actually introducing potentially infections into the patient. So if it is a mild case of SJS or TEN, do not encourage catheterization or even central venous. But if it is a patient who requires mandatorily, make sure that the patient is monitored for catheter-associated urinary tract infection. That is another entity. While the patient is on catheter, everybody forgets that the patient is on catheter. Unless you do a urine routine examination, wherein you aspirate from the catheter tube. Never pour the bag into the culture bottle, the urine from the bag into the culture bottle. That is what some of the nurses do. They do not know about this. It is your duty to say that you have to aspirate with a 2 ml syringe from the tubing and put it into the culture tube and then send it for urine culture examination and urine routine examination. This is mandatory. Likewise, when you are suspecting a bloodstream infection, say for example, the patient has been on the central line, after a few days, you find the patient's fever is still persisting, is the line infected, you want to know, take a culture swab, not only from the line where you have put a central line, but also from the opposite limb. Make sure that you take another blood sample, because there can be a contaminant here, a superficial contaminant from the skin here. But if the opposite limb also shows a blood infectious growth and both are matching, then you are justified in saying that is a CRIPC or a catheter-related bloodstream infection or a CLABC, that is central line associated bloodstream infection. So this is very important. The third thing which you have to look for is ventilator-associated pneumonia. If the patient has been put on a ventilator or the patient has a hospital-acquired pneumonia, then HAP is also called. So you have to be aware of this particular entity called hospital-acquired pneumonia. These are very notorious because the patient is having a shallow breathing, patient is bedridden for a long time, chest physiotherapy cannot be done because the patient has lesions all over. So there's a very strong potential, and also the upper respiratory is injured. So swallowing reflex is not there. Breathing is very, very shallow. Therefore, the risk of pneumonia is very high. Then the patient is not able to bring out the secretions properly. So unless monitoring is done properly, these patients you are likely to lose because of pneumonia, from where cardiac failure occurs and even hepatorenal failure occurs. So watch out for these early signs of potential infections as you carry through the days of treatment in the hospital. Now, when should you give an antibiotic? This is something which very often people ask, should I give an antibiotic and what should we give? We have devised guidelines and say that when the bacterial count is high from the skin or a catheter sample or a urine, or a blood is showing a leukocytosis or a very high neutrophilic count, or you have a urine routine examination where it's showing pus cells, or the patient is having a confused mental state or an anxiety and excitement, which may suggest that a CNS involvement with sepsis, or the patient is suddenly going in for hypothermia in a relatively stable patient, or any other site where you feel that there is a site of infection, then you are justified. The safest is considered to be macrolide group because the relatively lesser number of reactions, but it may not cover many a time. So you might have to go higher, but always keep a tab on the culture reports, keep the microbiology department in line with you all. Now coming to this particular thing, which is indigenous, we have developed it. I understand that it was in Calicut Medical College. Dr. Gobinathan sir was first instrumental in using banana leaves to actually put a non-adhesive or a non-adherent dressing beneath the patient's back. So what we usually steam it, and then actually it is half burnt sort of a appearance, and onto that the patient lies down and there is no sting of the skin to the underlying surface. So otherwise the skin peels off, it's very painful, tenderness is there. Most of these TEN patients will have tenderness of the skin. So this will actually prevent further damage to the skin. So this has been scientifically studied, in fact, by Dr. C.R. Srinivas, who was in Manipal and in PSG Coimbatore. And there is another interesting article, if you all are interested, by Dr. C.S. Surka and Dr. Svetlana Pradhan on this particular autoclaved banana leaf being used. Some centers are using it, but if you're interested, you can look at it. But one way to sterilize it would be this: use autoclaving, or alternately, after it has come after autoclaving, you can actually clean the entire thing with surgical spirit or with a chlorhexidine wash. But it should be very, very minimally done because the surface just peels off with that. Now, fluid electrolyte balance. Peripheral intravenous line has to be placed, and it has to be placed for a long duration. Ideally, the protocol in most hospitals is to do it every 72 hours to change the lines. But changing lines is not easy in these patients. So maintain the lines, but always look for evidence of phlebitis, because phlebitis is another source from which infection can get in and sepsis can occur. So phlebitis should always be looked at. Local infections at that site, erythema, redness, edema, or pus formation, or extremely painful, mobility loss, all of these can suggest that the patient is having a line infection, and that should be attended to immediately. The simplest method, very early pickup every day when you examine and you see that the line is, just give salt compresses that will reduce, keep the limb elevated, that will reduce the edema. And if necessary, you can also use glycerin maxil for dressings. So these are things which we usually do in our clinical practice. And vascular catheter tip culture is not recommended because usually you will get a lot of these pathogens which are commensals on the skin, and there will be overgrowth of these commensals also. So you will be actually misguided. So make sure that you do a symptomatic management there. But if you're sure there's an abscess there, definitely the pus has to be drained. And whenever there's an abscess, don't just go and squeeze the abscess right away. First and foremost, clean the area with surgical spirit, make a small nick or go under the abscess, squeeze out fresh content of the pus, and then only send it for culture. That is where you will actually get the true culture report. Most patients or most doctors just tell the nurses to take a culture swab. They go and take it superficially and they get a false report. Always take it from within them. And because these patients lose a lot of fluid, you need to put them on IV line or central line because they continuously are at the risk of having hypovolemia. Right? They need at least 3 to 4 liters of fluid per day, and dehydration, hyperosmolar urine, and acute kidney injury and pre-renal failure are very, very important complications which you should be looking for. Now, coming to feeding, always encourage oral feeds because the swallowing reflex actually helps the patient too. So you start with very simple liquid diets. You can then make it semi-solid and then make it solid. If the patient is not at all able to swallow even his or her own saliva, then is an indication definitely for putting an oral nasogastric tube. Otherwise, I would prefer not to use any invasive lines as far as possible if you can encourage oral feeds. Caloric requirements, keep it at 30 to 35 kilocalories per day, per kg per day, and proteins of 1.5 gram per kg per day to avoid a negative nitrogen balance. We have spoken about dressings. If you are not in the do not have access to banana leaf, you can always go in for soft paraffin gauze. Some have chlorhexidine in them, but sensitization can occur even to that. A single potassium permanganate bath regionally, not entire body. Whenever you're doing, when the patient is coming with grossly infected lesions, just a dilute potassium permanganate bath. You do it on the legs on one day. Tomorrow you can do on the back. So different areas so that you don't develop too much of toxicity because of overuse of dilute potassium permanganate. That's another way of cleansing the area. Oral and genital hygiene. Always patients feel very comfortable with normal saline. Give copious amounts of normal saline for oral rinse. They feel very comfortable when they put oral normal saline. Likewise for the genitalia also, rinses with normal saline are good. If the patient can tolerate after a certain point in time, maybe once or twice a week, I give a chlorhexidine or a dilute potassium permanganate oral rinse. But daily inspection of all mucosa is required, right from the eye to the oral cavity to the anal and vaginal or penile area. Now, coming to another area which has gained much importance in critical care dermatology, that is ocular care. Because this is an exclusive area where maximum morbidity occurs. And it is a preventable cause of morbidity. And that is why you have an entire set of ophthalmologists who are actually working on this. And we can be proud that India has actually contributed quite a number of research articles, and even the genetic testing has been done. I will come to that. So make it a point to have daily ophthalmic care, assess and reassess, watch for lid, cornea, scleral, conjunctival complication, and know about the fact that you can use amniotic membrane for this. So acute involvement, look for eyelid margin inflammation and hyperkeratosis, conjunctivitis with membranes or pseudomembranes. So some amount of mobilization is always required. I ask the patient to slowly mobilize the lower eyelids so that some amount of movement takes place. Otherwise, adhesions develop there. Or you can ask them to use the eye drops, which will, and get an ophthalmologist almost every other second day at least. And closely watch for corneal or conjunctival epithelial defect, because the cornea just melts. If you neglect, the cornea just melts. And even steroids can actually cause corneal melting. So you are put in a catch-22 situation where if you do it, you have a problem. If you don't do it, you have a problem. But still attempt to save the cornea as much as possible with the advice of the ophthalmologist. For severe cases, amniotic membrane may be required. This is a newer emerging trend which is occurring, to use amniotic membrane transplant. Chronic ocular involvement usually occurs when they have sequelae. Once they have been discharged and gone, you find that there's some amount of scarring. The eyelashes become distichiasis, you see. You get trichiasis, you get dry eye syndrome, you get eyelid malposition, which is very discomforting to the patient. They're not able to close their eyes properly because of the scarring. Chronic conjunctivitis can occur. And then there's something called limbal stem cell deficiency and corneal melt and infectious keratitis. All these cause even potential vision loss, endophthalmitis have all been encountered in Stevens-Johnson syndrome. So early starting of this, and cornea is one thing which you can save. So you can have specialized contact lenses. I'll show you how that looks. And sometimes you might need to send for surgeries for ocular involvement, whether it will be an eyelid surgery or a surgical procedures for corneal involvement, corneal detachment. So CLET, COMET, SOMET are all things which are used in ophthalmic parlance. This is called PROS. PROS actually is a copyrighted, it's almost like a lens, ocular lens. It looks almost like a contact lens. So it's just placed on the cornea. And this is not available in India as I know, but abroad it is available. But if any of you all know about it, please do intimate me also, because I would be able to procure this for those patients. I think ophthalmic hospitals may be having these benefits. The other is something called Procera, which is used for symblepharon. That's another patented thing which is used. So these are the different things which have been used. It's an emerging specialty where ocular care of Stevens-Johnson patients is coming up in a big. What is interesting is this particular research article. Before 2005, it was the Japanese scientists who had started focusing on ophthalmic SJS-TN with severe ocular complications. They found that cold medicines were the main cause in their country. And they found an association with HLA A206 and HLA B4403 as an association with cold medicine related. So that itself has become an entity. Look at this, is called CM SJS-TN with SOC. That is cold medicine Stevens-Johnson TN with severe ocular complications. So this later, they included a few more countries in their collaborative effort, and they brought out a finding, a research paper. And this is what it is. This was from Korea, Brazil, India, Taiwan, Thailand, and UK, an international collaboration. And incidentally, in the Indian study, they identified there were risk alleles. HLA-A 4403 was the most frequent HLA identified. And there was a major risk allele in the Indian population, whereas HLA-B 5701 and HLA-C 602 were protective alleles in the Indian population. So this is the contribution we have made to literature. Now, what are the prognostic factors which affect the outcome? If the patient is elderly, if the patient is having coexisting diseases, if the metabolic parameters are deranged, if the patient is having sepsis, nosocomial infections, or if the patient is having large area of involvement, or if the patient has a delayed reporting, these are all poor risk factors. So this table again is available in our guideline. So go through that, you'll be able to identify all those risk factors which. Now, how can I prevent infection in these patients? As I mentioned, barrier nursing, regular hand hygiene, avoid unnecessary insertion of urinary catheters, intravenous lines, or central lines. If used, they should be handled minimally, changed regularly, and monitor for focus of sepsis and keep the environmental controls correct. If you have the facility for air exchanges, if your ICU is having air conditioning, make sure that assessment is done for temperature, humidity, as well as air exchanges. And always activate sepsis protocols early in the hospital. So we have certain scorings which can be done in research institutes. We don't do in clinical practice, but these are broad parameters which actually help us. If the age is more than 40 years, presence of malignancy, tachycardia, more than 10% detachment, blood urea nitrogen more than 28 milligram per deciliter, glucose more than 252, and bicarbonate level less than 20. All these are prognostic parameters. So the mortality is very high if the scoring is more than 5. The mortality is almost 90%. Another score algorithm, they have from -3 to +3 for each of them. So scoring is done based on that. So those are where you are doing studies on SJS-TEN. This is worthwhile having this criteria for drug causality as well as for prognostication. So your checklist should have these things: ocular, mucosal, skin sequelae, sepsis, electrolyte imbalance, erythemias, temperature dysregulation, output and renal disturbances, hepatic and GIT involvement, pulmonary and ARDS prediction, neuropsychiatric involvement, nosocomial infections, and I forgot patient psychological support, which is very, and of course, rehabilitation from the physical medicine and rehabilitation department also very often is required. So these are all things which should be kept in your mind while you're actually dealing with the severe case of Stevens-Johnson syndrome or TN. So what are the complications? Almost every organ in the body can be affected by Stevens-Johnson if it is neglected and the patient comes very late. Now, what is the treatment of choice in SJS-TN? So we started with the story where steroids were actually implicated. So can I give steroids? So we went around and identify articles where steroid has been used successfully. So these articles, we have put it as references in our document. And you will find that there are people who use steroids and have brought out good outcomes, provided it started very early. Ideally, within the first 3 to 4 days, if you can identify and give steroids, gives wonderfully, and taper out very quickly so the patient does not run the risk of infection. If the patient is coming late, then what do you do? Give as far as possible only supportive management and an antibiotic treatment if required. Give supportive regional treatment. Systemic corticosteroid is a judgment taken based on whether the lesions are progressing. If you find that the lesions are erythematous, new ones are coming up, they are still tender and they are oozing or they are eroded, then and only then start a steroid, because the immunological status is still there. If the immunological status, the overactivity has died down, there's no point in giving an immunosuppressant. So the choice is yours, which steroid you would like to use. It can be either you can use a betamethasone or a dexamethasone, or some people use a methylprednisolone pulse, but you should be the master of that steroid. You should know what are the problems with the steroid. You should know everything about steroid, then only start your steroid. Because unless you watch out for the complications of steroid, you will create havoc for the patient. So especially when the patient is coming late. So make sure that you have given an antibiotic, allow it to settle, and then you can give after the first or second dose of antibiotic, then you can give your steroid so that you will not be creating a sepsis scenario. That's what I do. I usually give my first dose of antibiotic or second dose of antibiotic, then start the patient on steroids, right? Symptomatic management only on day 1. There are studies which show that you don't need to use steroid. Now cyclosporin is coming, which is much safer, lesser risk of adverse effects like steroids. So your choice is there. People are moving to cyclosporin, and I think quite a number of dermatologists have actually moved over to cyclosporin. There's also reports about intravenous immunoglobulin being used. There was a hue and cry that it's a game changer, but it has not been as beautifully, it is not a standalone drug. Maybe in combination with steroids, it gives wonderful results. But there are definitely studies for that. Now there are more studies on biologics like etanercept being used. Some people are even using JAK inhibitors in this. So the newer and newer drugs are being tried in Stevens-Johnson. Unfortunately, we can't do a double-blind control study. That is the reason why most of these are ethically not allowed, and therefore we have to take anecdotal reports and then finally give out these medications. Now, I'll just touch upon what are the pathogenetic aspects which have currently gained importance as far as Stevens-Johnson syndrome is concerned. One is photo-distributed Stevens-Johnson syndrome in TN. This was never considered as an entity. There is one beautiful article called Photo-Distributed Stevens-Johnson and Toxoplasmosis. They say that there should be a new diagnostic classification. They noticed in a certain set of patients, they did in 13 patients, that ultraviolet radiation prior to rash onset, along with the use of the drug, will give rise to a SJS-TEN, which is a finding which they have identified. And more so, they differentiated from other causes of positive Nikolsky sign. Mucositis, palmar and plantar rash, positive Nikolsky sign, prolonged disease course can actually help distinguish photosensitive reactions, whereas a negative DIF test or a direct immunofluorescence will help to say that it is not because of SLE or other photosensitive disorders. So these are the tests that they have done on each of these 13 patients, and you see all of them have negative DIF and a negative anti-nuclear antibody. So it was actually a photo-aggravated case. So there is a case for including this as a morphological variant or an endotype. These are all the different patients that they have looked at. So in that, they identified that there are certain drugs which are also more prone. Carbamazepine is more prone, sulfasalazine, ciprofloxacin, we already know photosensitivity can occur with ciprofloxacin, fluconazole, and chloroquine and sulfadoxine pyrimidine. Itraconazole, which we use so much, and lamotrigine and tramadol. These were the drugs which have been associated with this photosensitivity. But anyhow, this is a very just niche emerging area. I wouldn't say this is should be given utmost value, but definitely they have given us a food for thought. The second area which is important is non-drug related. So we do encounter patients who have not taken a drug, but they have SJS-TEN like presentation. So there's a systematic review on this. If you can go through this article, this will actually give you a good amount of non-drug related. So infections like mycoplasma and several other infections have also been reported. Radiotherapy, chemical substances like a lot of these insecticides and organophosphorus compounds, mercury compounds, trichloroethylene. These are all things which are seen in our surroundings. So we don't attribute it to that. And of course, other diseases, and even look at these plastics. Some of them can even polyvinyl chloride. They're all been identified as causes, which a chance association agreed, but we are not looking at that angle as a cause. So a host of viruses have now been intimated as an association with Stevens-Johnson TN, where a drug has been there or without a drug, it has occurred. So these are the viruses which have been documented. And these are the bacteria, Streptococcus, Meningococcus, Mycoplasma, and Sepsis states. Now, this concept of virus reactivation is something I want to emphasize. All of us are surrounded by herpes viridae group of drugs. And these viruses can actually get reactivated in a patient who has a drug reaction. And that work was done by this gentleman called Shiohara. His team in Japan actually did a pioneering work in 2014 and published about the importance of viral reactivation. So if you need to understand viral reactivation, you need to understand about resident memory T cells and T regulatory cells. So what are these T regulatory cells and what are these resident memory cells? If you look at the T cells, you have 4 different types. They are effector cells, they are regulatory cells, they are memory cells, and the NK cells. The memory cells itself are of 3 types. These are called the effector memory cells, TEM, the central memory cells, and the resident memory cells. These are crucial for us. And on the regulatory cells, you have FOXP3 positive cell and a FOXP3 negative cell. Now, mind you, of these, I am concentrating only on the regulatory cells and the T resident memory cells. T regulatory cells are inhibitory. They inhibit the cytokine activation and the T cells from forming more resident memory cells. Whereas T RM cells are activators. So they bring about more of a cytokine response. So one is actually acting against the other. So I'll give you this example. A patient who has an FDE on one side and a patient who has TN on the other side. Both of them have blistering, both of them have erythema. Why is it that the person has extensive involvement, the other person has a very localized involvement? Because some people have considered FDE to be a localized TN. The answer lies in this. The regulatory cells are maximally present in the margins, and the resident memory cells are present here in the center. And this progression is occurring with the resident memory cells. But these regulatory cells are very active in FD, and therefore they limit it. They don't allow it to expand. Here, the regulatory cell activity is very low. The resident memory cell activity is very high, and therefore you have a spread of the entire process. This is the current explanation as to why you have the same clinical presentation, but in a different severity. The last point which I want to also emphasize is SJS-TN and DILI, or drug-induced liver injury. Drug-induced liver injury and SJS-TN can coexist because there are multiple factors involved here. You have the hepatic injury, you have the disease state, you have hypoalbuminemia, you have drugs being given, the food intake, the sepsis acting on the liver. So this is a very important thing to recognize. So you have to look for rising titers of the SGOT, SGPT. So make it a point in your monitoring, you also have SGOT, SGPT being looked at to look for whether the patient is having hepatitis, especially in the context of SJS-TN and Dress syndrome. So a lot of studies are coming, and the different types of injury patterns are also being recognized. I'm not going too much into detail. I've just given you a small teaser sort of. The last and the most important area of research now is genetic testing. Can you predict that a person is likely to develop a Stevens-Johnson syndrome? Because there is a legal implication there. So there are instances where it's been used as a predictive tool and for prevention. So this particular article gives you very good evidence of what are the genetic markers which are being done. And this involves a lot of these studies. This review article, actually, a lot of these studies were done in India. Notice this. This is Mehta et al. Actually, is Dr. Timir Mehta from Gujarat, Dr. Agarwal from Chandigarh. Then you have Dr. Ramanjam, who is from New Delhi. So a lot of these Indians have contributed to this. And this Dr. Kanabiran has actually done a lot of work, as I mentioned, about severe ocular complications. So that person actually identified all of these HLAs. So you can predict that a person bearing this particular HLA B type 4403 is more likely to develop an ocular complication if he has an SJS-TN. So that has been implemented on ground. They found that if you do it in certain populations, it can be done. So certain Asian countries like Taiwan, Hong Kong, Singapore, Thailand, they started testing for HLA-B 1502 screening program before the prescription of CVZ, that is carbamazepine. If the patient screened positive for this allele, they are provided alternative medications. And then what happened? In Taiwan, they found that there's a significant decrease in the incidence of carbamazepine-related SJS-TN. So this was used as a predictive tool. Similarly, from Thailand, we have not done it because of the expense. The government doesn't support us. So if this tomorrow, if there is an opportunity where the patient wants to know that there is a predictive factor, so think about this aspect of genetic testing. Now coming to Dress syndrome. A typical case history of a Dress syndrome is like this. A 25-year-old man on treatment for follow-up of road traffic accident. He was started on phenytoin recently as seizure prophylaxis for head injury. 3 weeks later, he develops this rash, has facial edema, cephalocaudal progression, fever, cutaneous pain and fatigue, and minimum mucosal involvement with palms and soles spared. So this was the rash that the patient actually presented, referred from neurosurgery. And so this was a typical case of Dress syndrome. Having said this, this is not always the presentation. It can present in different variant formats, and it has different names also. The term Dress has held on due to some reason, but actually the term should have been drug hypersensitivity syndrome, as far as I am concerned, because eosinophilia is not always seen in these patients. You don't always find hepatic enzyme elevation in these patients. So a drug hypersensitivity or a DIHS would have been a better terminology. Here you have a severe acute drug reaction defined by the presence of fever, skin eruption, and most importantly, you have systemic findings like enlarged lymph node, abnormal liver function, renal impairment may be there, pulmonary or cardiac infiltrates may be there, and hematologic abnormalities. These are things to look out for in these patients. So it was initially diagnosed with the anticonvulsants, and therefore it was called anticonvulsant hypersensitivity syndrome. But later we find that so many other drugs can also cause, especially allopurinol dapsone syndrome you have seen is also a presentation like this. Minocycline, which we prescribe for acne, can present like this. And more recently, nevirapine, which is used for HIV. Most of the manifestations will occur within 2 to 6 weeks after initiating therapy. And they usually present without much of sequelae. But a fatal outcome can occur in around 10 to 40% of cases if the progression is very severe or if the steroids is withdrawn very fast. They come up with relapses and then they go in for morbidity and mortality. The skin is the most common organ involved. Around 90 to 100% of patients with Dress syndrome will have skin. Next is liver. And then comes hematological involvement in some form or the other. Of course, muscle, kidney, heart, and lung can also be. Mild cases will have only maculopapular exanthem, mild elevation of LFT, elevated CPK levels, hematuria, pericarditis, eosinophilia will be seen in around 80% of cases. But these other things may also be contributing. Moderate cases, you will find myositis, nephritis, carditis, and all. But severe cases, you are likely to get this sort of a presentation. With Stevens-Johnson, fulminant hepatic necrosis, rhabdomyolysis, renal failure, congestive cardiac failure, ARDS, aplastic anemia, because there is a profound bone marrow suppression. So that is where you will identify that actually the virus plus the genetics plus the drug, all three of them are acting on these areas. And most of these patients, 90% of them will have a fever and around 87 to 90% will have rash. There are several criteria for Dress syndrome: Registrar study group criteria, Japanese consensus group, and the Bouquet criteria. Most often people use the Registrar study group criteria because eosinophilia is quite commonly seen. But significantly, the Japanese consensus group says HHV6 reactivation is important and presence of all 7 criteria: typical DIHS, and if it is atypical DIHS, except lymphadenopathy and HHV reactivation, the rest of the manifestations will be there. So these are 3 criteria which you should be aware of. And these are the drugs which have already been established and known to cause Dress syndrome. So remember, allopurinol, minocycline, abacavir, azathioprine can also cause. Sulfa drugs we all know. Of course, the anticonvulsants, including lamotrigine. What is the mechanism? If somebody asks you in your PG examination, why anticonvulsants cause? Because they all have this arene oxide pathway. These patients have an altered arene oxide pathway, and that is why they are more likely to develop this. Exact cause for azathioprine is not known. For abacavir, it is the cyclopropylamine, which is the reactive product which causes this reaction. So allopurinol, it is formation of oxypurinol. I mentioned it is not always the rash which I showed. That is the exanthematous rash which you present. Patients actually present very often with papulopustular eruptions, where we find it difficult to say whether it is an AGEP or a Dress syndrome. So there, the systemic involvement actually gives you a much better evidence. And there are cases where there is an overlap also. You can have patients presenting with exfoliated dermatitis-like presentation, or an EM or an SJS-like presentation, which I mentioned some time ago, a colleague on ATT who actually developed this sort of a presentation. Now, can a drug have a specific type of presentation? Can you say, but the presentation, this drug is more likely? So then you have a long list. There are some researchers who have done that. They found that with lamotrigine, fever and toxic epidermal necrolysis were more often. Renal dysfunction, eosinophilia without fever, several months after start of treatment was allopurinol. Peripheral adenopathy, eosinophilia and heart abnormalities, and eosinophilic pneumonopathy with minocycline. And GI disturbance and viral pneumonia-like symptoms with abacavir. So there is some association being evolved, but I don't think this is hard and fast. But at least you have some pointers to suggest, yes, this may be a presentation. Regarding the pathogenesis, the whole lot of gamut, just like SJS-TEN, there's a lot which has come in. You need genetic susceptibility, you need reactivation of the viruses, you need drug-specific T cells as well as antiviral specific T cells. So these will produce cytokines, major one of which is now IL-5. IL-5 is a cytokine released by eosinophils. So IL-5 causes hypereosinophilia, also causes inflammation, And this hypereosinophilia causes a lot of these symptoms. So the role of eosinophil in Dress syndrome is crucial. And that is why newer therapies have targeted IL-5 as a target. This is the reactivation of herpes virus 6, which was a very important part of the pathogenesis of Dress syndrome identified by the Japanese group. Somebody has actually tried to differentiate rapid onset Dress versus delayed onset, less than 15 days if it is rapid onset and more than 15 days if it is delayed onset. It can go up to 2 to 8 weeks, but we see, of course, more than 15 days is what we see with the anticonvulsants. Almost bang on 21st day, 23rd day, you will find these patients coming with a rash from the neurologist or a neurosurgeon, right? Whereas the other drugs, antibiotics and all, if they develop Dress, they usually develop less than 15 days. But otherwise, there's not much to differentiate among the same. Adult versus pediatric, is there a difference? The only major difference is probably the culprit drug. Anticonvulsants, allopurinol and sulfonamides and antibiotics are more often seen in adult. Whereas in children, you will find again anticonvulsants because they may be prescribed for absence seizures or generalized tonic-clonic seizures, antibiotics and NSAIDs. Allopurinol is not commonly seen in that list because hyperuricemia is rare. Pathogenesis is somewhat similar, but here one must read that there is a long-term sequelae. They are more vulnerable to autoimmune disease. So that is very important in pediatric because they have a longer lifespan where they are more likely to develop. So they should be watched for autoimmune diseases. And this is the registrar criteria. And you should have a knowledge of the mimics of Dress syndrome. Are you dealing with infections, rheumatologic diseases, hematologic disease, or pure dermatologic disease like Stevens-Johnson or toxic? So a little bit more of reading about these diseases will actually give you a better clinical picture. And as you start seeing cases, you will be able to recognize that it could be a particular viral infection. Say, for example, a person has an adenovirus infection, you would identify hemorrhagic conjunctivitis or a respiratory infection, which is very severe. EBV patient or a CMV patient may be having some amount of lymphadenopathy with a rash. So that may be the presentation. A enterovirus may be presented with a gastrointestinal presentation followed by Dress. So all of these are mimics of Dress syndrome. So you should be aware of that also. How do you treat? Very simple. First and foremost, withdraw the suspected drug. In this Dress syndrome, in comparison to Stevens-Johnson, the difference is you're giving steroid here, but you're giving steroid for a longer period of time and you taper it very gradually. Do not taper it very fast because the patient will invariably relapse. So you have to handhold them and tell them it's a long-term therapy which is required, and you cannot withdraw the drug very fast. So you can always actually go in for an alternate drug like cyclosporin, which has been tried, IVIG has been tried, even some people have tried antivirals. But strangely enough, steroid works best. And of course, like SJS and TN, you have to early recognize the complications and give a lot of fluid electrolyte imbalance measures, because again, you are dealing with a case of acute skin failure. For pediatric Dress syndrome, this is an algorithm developed by the Euroscar group, the European group. They say immediately suspend the culprit drug. If it is mild disease, you go in for supportive and symptomatic therapy, give the fluid and electrolyte support, and clinical and lab stabilization is sufficient. If it is moderate to severe, you have to give systemic steroids at 1 milligram per kg of prednisolone. And slow tapering over 3 to 6 months is what is recommended. This given in dotted line is all empirical or experiment. IVIG, IL-5 inhibitor like mepolizumab or benralizumab, cyclosporin, plasma exchange. These are all being tried in different reports, but this is the mainstay as far as Dress is concerned. Right? If there is contraindication of use of steroid, then go in for the same. Start exploring. But IL-5 inhibitor is not yet available here in India, to my knowledge. So coming to another scar reaction, that is AGEP. What is the clinical presentation of AGEP? Usually they present with studded micropustular eruptions all over the body after a febrile illness. Short duration. They don't have any pre-existing illness. Either an antibiotic was given or an analgesic was given, and they develop with a flurry of or a host of pustules developing predominantly on the flexural areas. That is the take-home. Predominantly on the flexural areas, but of course they can go in for a generalized rash. So when you are encountering a patient with generalized pustular eruption, there are a few things which one also has to consider as a differential. One is pustular psoriasis, the other one is subcorneal pustular dermatosis. How do you differentiate the two? I will come to it. Can we use some labs to aid the diagnosis? Does a biopsy help? These are questions which are asked. And how do you manage such cases? So this is a presentation where the patient has had not only flexural but generalized. So this patient actually was on penicillin and patient developed this. So these are common drugs which we also give. So patient may be on HCQ for a rheumatological problem, or maybe have been given HCQ by us for a photosensitive eruption and develops this sort of a presentation. So one has to consider AGP in mind because it goes off very quickly once you withdraw the drug. And a very short course of steroids or topical steroids is sufficient. Unlike pustular psoriasis, where the patient would have had previous history of psoriasis in them. So you should know how to differentiate pustular psoriasis versus AGEP. First and foremost, both will have generalized presentation, both will be pinpoint pustules, both will be non-follicular, both are acute onset. Then you have to ask for family history of psoriasis or a personal history, pruritus or burning, whether the patient has arthritis, that may be an evidence. And of course, whether the patient previously had a psoriasis and was given a steroid or was given a topical preparation which was withdrawn and that produced the pustular eruption. Then it goes in favor of a pustular psoriasis. But having said that, you can get de novo pustular psoriasis without any previous history of psoriasis. That's a very small segment of people. But that will require then go to the next level and do a histopathology. And histopathology will give you a little more features. In pustular psoriasis, you will have a subcorneal pustule. Even here, you will have a subcorneal or intradermal pustule. Acanthosis and papillomatosis will be here, which will not be here. Whereas spongiform pustules of Kogoj will be there in pustular psoriasis. Here, you will find necrotic keratinocytes like you find in EM. You'll also find eosinophils and absence of tortuous blood vessels. So the diagnosis becomes much easier when you do a biopsy. So this is the importance of doing a biopsy in a generalized pustular eruption. Routine works you have to do. You have to send a CBC. You have to do a C-reactive protein. You can do a liver enzyme and creatinine to identify if there is systemic involvement, and infectious disease workup may be required. If the patient is of reproductive age group, do not forget to do a pregnancy test because during pregnancy also pustular eruptions can occur in the form of GPP. And sometimes hematologic malignancies can occur, then presenting as this sort of a presentation. Therefore, they suggest that you can do a protein electrophoresis if necessary, but nothing like doing a skin biopsy. Mycoplasma pneumonia again is implicated. This is the classical histopathology of AGEP, intraepidermal pustule or a subcorneal pustule. And along with that, you're finding a cluster of several neutrophils and edematous papillary dermis and perivascular lymphocytic infiltrate is also seen. Sometimes you find eosinophils also. So once you've made a diagnosis, stop the drug and declare to pharmacovigilance, which we don't do, we don't have the habit of doing. If it is an adult, you start potent or super potent. Whereas if it is a pediatric age group, give a mid potent. Oral steroid can be given on a case-to-case basis. And never forget to give a drug allergy card to these patients. Allergical workup in the form of patch testing, we don't do here, but in Western countries, they do that. The last segment is on bullous drug reactions. We have a lot of bullous drug reactions which can go in for acute skin failure. It can be severe. So some of them are drug-induced pemphigus, drug-induced bullous pemphigoid, drug-induced linear IgA bullous dermatosis. Scar is one where SJS, dress, and generalized bullous FDE can present as bullous. Phototoxic drug reactions can present as bullous lesions. Porphyrias, drug-induced porphyrias can present as bullous lesions, and even anticoagulant-induced skin necrosis like this can also present as bullous lesions. So when you have a patient with bullous reaction, ask for the specific history of the drug, and the type of morphology of lesions will give you a clue. I have given you clues for the other three scar reactions. So the point is whether you're dealing with a bullous pemphigoid or are you dealing with a Stevens-Johnson. So you have a lot of other features. Mucosal lesions may be lesser seen in bullous pemphigoid. LABD is again difficult to differentiate because that can also present sometimes with mucosal lesion. So then an immunofluorescence will actually help you. So these are the pointers which you look on a systematic basis. If you keep dissecting it out, you'll be able to diagnose the and arrive at a final diagnosis so that the patient gets the correct treatment. So this is actually generalized bullous fixed drug eruption. For those who have not seen generalized bullous FDE. In fact, during COVID, I had a patient who had this GBFD almost involving nearly 60% of the body, multiple lesions. So it's not the drug alone which is important. You need a viral infection also with that. Of course, the histological features that recommend that suggests that it is a drug-induced BP and not a classical BP would be the blister cavity, which is rich in eosinophils, and similar to that, you can also find linear deposition of IgG and C3. So that makes it very difficult to differentiate. But there are certain pointers. You can click a photograph of these. These are pointers which actually will help you to recognize whether it is a drug associated or an idiopathic bullous. Sometimes drugs can induce bullous pemphigoid also. But here you will find that mucosal involvement is very rare in idiopathic bullous pemphigoid. And frequently it involves the extremities. Here drug, you can have even involvement of palms and soles, and mucosal involvement may be present. That is one pointer which I usually take. Rest all are very, very overlapping features are there. So to summarize, I have given you an overview of the magnitude of severe cutaneous adverse drug reactions that we encounter in clinical practice. I've been in this specialty for 2 decades. I've seen so many different types of cases. So it sometimes for you all, it must be overwhelming that you have such a wide spectrum, you need to know so much. You learn on the way, little by little, bit by bit. Every patient is an experience for you. But if you show sincerity at your work and you show sincerity towards the patient as well as towards the knowledge that you gain, you will slowly start gaining the information that you need. So again, quoting Shelley, the art of looking calls for attention to the overlooked areas. And this cannot be done casually. It must be done with bubbling curiosity. So hospitalize if necessary, seek serendipity, chance that you will find something new. Don't give up. That is a take-home message from me. Thank you for your patient listening.
Thank you, Dr. Abhay, for a very wonderful overall, or rather, it is an in-depth discussion on various adverse cutaneous drug reaction and related areas. Very beautifully told and very beautifully exposed. Anyway, all the postgraduate students are benefited out of your presentation and talk. I thank you for your participation, and on behalf of myself and East West Pharma, I extend a gratitude to you, Dr. Abhay. Very much for all the participants. Dr. Abhay.
Yes, sir. Thank you.
Thank you. Thank you very much.
Thanks for the opportunity, sir. And it's great to see a wonderful set of young budding dermatologists. Hope I have contributed something to their knowledge. Thank you, Naveen. Also
Thank you very much, Doctor. Thank you, Doctor. Thank you very much for a wonderful opportunity. And East West Pharma is always committed for the academic sessions, and we heartfully extend our gratitude to the speaker who has given a lucid presentation for the benefit of our PGs. It's extensively very good talk, and the recorded video is available in our East West platform. You can approach our East West Pharma people. So it is available in our platform. The winners will be received a certificate as well as directly. So thank you for Dr. Sir to such wonderful speakers for the benefit of PGs. Thank you so much, Doctor, and have a great day to all. Happy weekend.
Thank you.